Good afternoon. Today we are going to discuss another very common entity which is known as salmonellosis or enteric fever or typhoid fever. In Indian continent, people used to call it Motijhara. So we know that India is endemic country for this disease. So it becomes vital to know everything about this disease. That how we are going to treat these patients in our OPD. So let's get started. We will see everything one by one. First, we will start with pathogenesis. And that how the disease is spread, the mode of spread is contaminated food and water. It is not insect. So what people usually think that it is spread by some insect. So we have to counsel the patient that this is the disease which is spread by the infected food and water. So in the treatment part, you have to counsel the patient about the food hygiene and water sanitization. Second thing, what is a very common practice is self-medication, not only in the India, outside the India also. The patient used to go to some nearby medical store and buy some medication for many health-related issues. So what they habitual to get from the medical store is antacids or PPI, and the second most common thing is antibiotics. So both which disturb the intestinal microbiota and stomach acidity. So they break the barrier, they break the barrier and make patient prone for the infection. So once the patient is infected, the incubation period is going to 5 to 21 days. Yes. So once the patient is having some contaminated food or water or getting or have infection with this bacteria, the symptoms will come after minimum 5 or maximum 21 days. Very brief about the clinical features. The most common and most prominent symptom is none other than fever, that is prolonged fever or high grade fever. The grade is usually high, temperature more than 101 degree Fahrenheit in most of the cases. And the second most common is abdominal pain, and this is a symptom which can mislead the physician to diagnose the patient, as when the pain is more than the when patient is having pain more than the fever, the patient complains of abdominal pain only, and in this case physician may make the diagnosis of some abdominal infection like enteritis, colitis, or some worm infestation. So this can lead the patient to suffer for prolonged period. Rojo spots, we continuously study in our theory books that these are the things which present in the enteric fever. What we have to know clinically, that they appear at the end of first week. Means if the patient is came within 6 days with fever, the rogue spot may not be there. Second thing, these are very difficult to distinguish as they are the very tiny paddocky-like structures seen over the anterior chest wall, and they are blanchable. Means if you apply the pressure, they can blanch. So, and they resolve within 3 to 5 days. Means if patient came within the period of 7 to 12 days of fever, you may find the rose spot. Below this or above this, you may not find the rose spots. So these are not the only thing by which we will make the diagnosis of enteric fever. So these are the things which support the diagnosis. They are not the diagnostic. Few words about the diagnosis which we have to know in our clinical practice. One thing which we must learn, that Vidal test is not the only test which make the diagnosis for enteric fever. There are many tests, many other tests also, and it is usually negative in first week of illness. Means if patient present in less than 6 days of duration, the test is usually negative. So what will we do when patient came with less than fever of less than 6 days of duration? So in the first week, the test which is diagnosis is culture. Culture from where? Either from the bone marrow or from bowel fluids. In bowel fluids we have gastric aspirate, we have urine culture, or we have stool culture. So these are the three culture tests by which we can diagnose the patient as enteric fever in first week of illness. After the first week, we can go for Vidal test, but in the first week we have to order the culture only, because in the first week Vidal test is negative, so we will not going to get anything with the Vidal test. Typhoid or antibody against the salmonella antigen is which comes positive in first 2 to 3 days of illness. Means you can, if the patient presented to you with history of 2 to 3 days of fever, you can order the typhoid or IgM antibody, not the IgG, IgM antibody, which is in the market or in the lab. It is available as IgM typhoid. So this is a test you can order if the patient is having fever of 2 to 3 days. If it comes positive, you can make the presumptive diagnosis of enteric fever and you start the treatment, right? And when we talk about the Vidal test, titer is very important, as we know that there are though two antigens, one is O and another is H. The titer range above 1 is to 180, and for H it is more than 1 is to 320. If the titer is above these range, we will think of Vidal test, or the titer is rising, means once you order the test, the titer might say, let's say it is 1 is to 40, and when you reorder the test after a few days, it comes 1 is to 320, means titer is rising. So this also can make the diagnosis of enteric fever with high grade of fever. Means the fever must be there, means symptoms must be there with the history of rising titer, right? So titer is the important. Single value of the titer is or none of use until unless it is more than 1 is to 320. If it is below 320, we cannot make the diagnosis of enteric fever solely based on the Vidal test. So we come to the differential diagnosis, very close, three very common and closed diagnosis with enteric fever. One is malaria, second is dengue fever, and third is leishmaniasis. Malaria, as we know, we can easily differentiate with the malaria antigen test or peripheral smear for malaria, PS4MP. We will see the ring ring or gametes for the malaria. If we found it, we will make the diagnosis of malaria, not the enteric fever. The fever pattern in malaria can be same as enteric. As you know, the falciparum malaria can present with continuous or daily fever. There might not be intermittent fever as we usually see in case of vivax. These are the only two strains which is common in Indian continent or in most of the world. In dengue fever, the fever pattern is typically break bone fever, means the body ache is much higher. Second thing, when we investigate the patient, we order the CVC and we will see the thrombocytopenia and raised hematocrit, means the patient are dehydrated, so hematocrit will be high and the platelet will be low. If we found these findings, we will think of dengue fever. In leishmaniasis, the abdominal symptoms will be prominent, means the pain will be higher than the fever. First, fever may not be very high grade, right? The pain can be dull, aching, or continuous pain. So once the patient is having pain only, we will think of leishmaniasis. So how we are going to order our test in case if patient came to us with fever of less than 6 days, means patient is complaining that he is having fever, mild abdominal pain for say 4 or 5 days. So you will order a CVC, malaria antigen test, and if you are suspecting enteric fever, then you can ask for culture, which can be urine, stool. You can be urine or stool or gastric aspirate, which is sometimes difficult. So urine or stool is a good option. If the fever is of more than 7 days, yes, you will include peripheral smear also, right? Peripheral smear, you can find sometimes very striking features. If fever is more than 7 days, you order, including these tests, you will remove the culture and you will add blood Vidal. So the after the second week, we can order the blood Vidal test and we will see the titer if it is rising or more than, if titer is rising or more than 1 is to 320, we can make the diagnosis of enteric fever and then start the treatment accordingly. So now we start with the treatment part. We categorize the patient into category. One, the patient is stable, and one, the patient is critical. First, we will discuss with the stable patient. Means the patient came to you in your OPD with the history of some fever, abdominal pain, or few other symptoms. So in the previous time, we categorize the treatment based on the ciprofloxacin sensitivity. Means the patient is either sensitive to ciprofloxacin or resistant to ciprofloxacin. If it is sensitive, the drug which you usually prescribe was ciprofloxacin. The dose was 500 mg twice a day for 5 to 7 days. But now this drug is almost outdated because there is a too much cases of ciprofloxacin resistant. One, and second, as we already discussed, that we have to treat the patient in our first contact. So for the treatment of first and the first contact, we don't know the sensitivity status. So we will not use the ciprofloxacin as a first line of treatment, as we have many other good drugs in the basket. So the azithromycin and cefixime, these are the good options we have easily available everywhere in the market. Azithromycin we use 500 milligram once a day for 5 to 7 days, and cefixime we use 200 milligram twice a day for 5 to 7 days. Very simple. And cotrimoxazole, previously it was used and said that it was a good drug for salmonellosis also, but now it is not routinely used in salmonellosis. Not routinely used. In some cases we can use, but not routinely. We have another drugs, and the patient, stable patient, they respond very well to these drugs. And what we can do best for the patient is we advise the patient, we advise the drugs which are available in combination, means two drugs with combination, and we can, the therapy can be advised for 5 to 7 days, and then after that we will see the response. In the market, we have very good brands available widely all over the world, not only in India, all over the world. So, azithromycin, we have Agithal or Agi. Its strength is 250 and 500 milligrams. If we are using 250, then we will prescribe twice a day. If you are using 500, you will give once a day. The therapy will be given for 5 to 7 days. And Cefixime, we have Jiffy or Texim O in the market. The strength is 200 milligram twice a day, and we will give it for 5 to 7 days. 5 days is usually given initially, then we will see the response and ask the patient to come for follow-up. And cefodoxime is another cephalosporin, second generation cephalosporin, available with the clavulanic acid, and in the market is available as Comport CV, Macport CV, or Goodsef CV. The strength is 325, and we will give it as a twice a day for same 5 to 7 days. So these are the solo drugs available, few solo drugs available in the market. Many more drugs are available, but these are very commonly prescribed. In the combination, what we are usually practicing in our OPD is giving a combined drug, and these three are the very good drugs for the enteric fever initially for the first contact. So one is Jiffy O. Jiffy O means cefixime plus ofloxacin. The strength we have 200 and 400 also. We will start with 200 only, twice a day for 5 to 7 days. If the response is poor, means the fever is down but not completely, patient didn't recover completely, so we will increase the strength and then advise again for 4 to 5 days. In Goodsef or Compodo, we have cefodoxime के साथ we have ofloxacin, and we can advise it twice a day for 5 to 7, 5 days, say initially 5 days, and then we will see the response. Patient usually respond well, very good, very nicely to these drugs. Zostem O is the very new drug in the market, that is ceftazidime Pavaxil. This is third generation cephalosporin. This is third generation cephalosporin and available in the oral form. So the strength is 200 milligram, and this is a little costly drug. So if the patient, you think the patient can afford, you can advise this drug, and the response is very nice. 200 milligram BD, same for 5 days. So these are the oral drugs for the stable patients. Once the patient is critical, we have to admit the patient in ICU. As we all know, for the ICU we will start fluid therapy. We will send all the routine sample. As we have enteric, as we are discussing enteric fever, we will focus on enteric only. There can be multiple diagnosis, all the routine tests, and we will start with antibiotic, and cephalosporin are the very good. So in the cephalosporin we have ceftriaxone with salvectum, that is available in 1.5 grams, and we will give it twice a day. We can start, if the patient is very sick or in altered sensorium, we can start with Pibjo. Pibjo means piperacillin plus tazobactam or salvectam. We have in the market with 4.5 grams, and this is given thrice a day. So we will start with these two antibiotics with supportive therapy. Supportive means, you, as we have started fluid, we give antipyretic like paracetamol, A patient is having some other symptoms, then according to the symptom, we will start the treatment. So far, so now we have discussed the two patients in stable and critical. Two patients we have, critical we having this treatment. For a stable patient, we will start one antibiotic, one antacid to counter the acidity, and plus antipyretic if patient, as we know, patient is having fever, if abdominal pain is there, so we will give some antispasmodic also. So this is our treatment protocol for a stable patient. In critical patient, we will admit the patient in ICU and we will start with these patients. So this is all about the enteric fever. You can, I think, with this knowledge, you can manage the patient